Welcome to Generate Health's fifth webinar, Navigating COVID-19 for Moms and Babies. My name is Carrie Mellentine, and I am the Manager of Strategic Initiatives for Generate Health. As customary, before we get started, I want to share some housekeeping information. Because of the number of attendees, we have muted all lines. However, we do encourage your questions and information sharing. Please use the Q&A functions at the bottom of your screen to send us your questions. We will address questions after all panelists have spoken. Next, use the chat box for information and resource sharing. We will capture this information and send it out after the call. We are recording this webinar so it can be shared with others later. Generate Health is a maternal and child health coalition. We were founded 20 years ago, and our mission is to mobilize the region to advance racial equity in pregnancy outcomes, family well-being, and community health. We see our role in this crisis to convene the maternal and child health community to share information about how people who are pregnant postpartum are at risk for COVID-19, coordinate resources that respond to the needs of service providers and community members, and identify collective action opportunities. Today's webinar will have three parts. First, we will hear from Mia Doherty, a community leader, about the concerns and stories from families in the most affected communities. Following Mia, we will hear from Karen Bradshaw, Director of the Care Transitions Initiative with St. Louis Integrated Health Network. And finally, Sally Hayward, Strategic Projects Manager with Behavioral Health Network. Karen and Sally will share what the COVID-19 Regional Response Team is doing in the health and behavioral health arm of the team. We will have time for Q&A after the entire presentation of the speakers. Please enter your questions in the Q&A box during the presentation, and again, they will be answered at the end. Please use the chat box for sharing any resources. So now I'm going to turn it over to Mia, who will share her stories.
Hi, good morning, everyone. It's a pleasure being here. I do want to share some experiences and concerns that that the community have shared with me, as well as the experiences that I have during the COVID-19. So first, I want to touch on the healthcare, the accessibility to the testing for the coronavirus, and so it's well known that there are the quote unquote Black diseases, such as the hypertension, cardiovascular disease, lupus, diabetes, kidney failure, autoimmune disorder, not to mention metabolic impacts of chronic racial stress. With that being said, that leaves African Americans at a higher vulnerability to the coronavirus itself. And the testing for the coronavirus was not available to those African Americans, especially in the zip codes where it has had a higher impact. Actually, it was the opposite, that the testing facility had opened in Chesterfield, which is nowhere near any Black community. It was available to basically the white community with where there is higher income area. And when the testing was open through the local clinics, Athenia, it was offered to the community with restrictions. You had to either go to the ER or you had to have documentation from your doctors. In Chesterfield, they had a drive-through that if you just showed symptoms, you were able to get tested. With that being said, one of the community members shared her experience that she is an essential worker. And for a lot of the African American communities, it's not uncommon for grandparents to take care of their grandchildren. So those essential employees would say go to working from a gas station or working at Walmart and go straight home to where their grandparents live. So one of the community members shared her anxiety of coming home and having to isolate herself from her grandparents because she was afraid, like her anxiety was up so high that she would, compromise her grandparents' health. Another community member shared that her son had hurt himself to where I believe it was like a open wound on his arm. And she had already suffered from anxiety, but her having to go to the hospital with her son sent her basically overboard to where it sent her into a full-on panic attack. When she got to the hospital, she was like, I just need to get out of here. I just need, could you please just hurry up this process? Because when she went to, I think it was Children's Hospital, it was so much going on with COVID-19 to where they had her waiting in the psych ward area. So it really just sent her over the edge when she couldn't get out of the room. When she tried to leave, the door was locked and she was like, let me out of here, and it's on top of everything else, the trauma that people are dealing with. Now you're toppling with the anxiety of what is going on. And COVID-19 has basically, the structural racial discrimination has adapted to COVID-19. And my experience with the adapting is, I went to Walmart a week and a half ago with my daughter, and thank God I have transportation. So I go to Walmart, and right before I walked up to the door, a lady stopped me and she said, because me and my daughter, we had masks on, she stopped me and said, they're not taking kids at this Walmart. You can't bring your kid in. And I said, what do you mean you can't bring your kid in? She said, well, you can't bring your kid in this Walmart. She said, but you can bring in any other Walmarts. Now, mind you, this particular Walmart basically caters to the higher poverty areas. This Walmart also caters to single moms, in those particular zip codes. So for me, it was disheartening to see these mothers that caught the bus, transportation to their local Walmart, but have to get on the bus empty-handed, not with the essential items that they came for, whether it be milk, whether it be diapers, food, that they were not able to bring their children in Walmart, which is basically the people that they mainly service. So I had to drive out to a further Walmart, which it was no problem walking in with my daughter. Another incident is the transportation. We all know, everyone here, that the transportation is so broken. But during this COVID-19, it has, like I said, it has adapted. It has shined a light on the mom, especially the one that I have been in communication with. Her son, newborn baby, had a doctor's appointment for a well baby checkup. Now her fiance is an essential worker. So he's in and out, in and out the house. So she was not looking forward to this checkup, but just that ease of mind to say, okay, my baby doesn't have COVID, because, we've seen the news and we see that there are kids dying. There has been a baby that have died from the COVID-19. So she was looking forward to just have that peace of mind. And she made an arrangement for transportation that never came. She made 2 arrangements for transportation that never showed up. And she messaged me and said, what do I do? Because as a mom, when you don't make it to those doctor's appointments, it doesn't fall back on transportation. It falls back on the parent. It makes it look like you were neglectful. And so yeah, it's been so many different areas of discrimination that I have witnessed. And even for me, the beauty supply stores that have closed, the beauty supply stores in the African community has served a major essential point for African Americans that have, like for my daughter, she has eczema of the scalp. So for me to be able to go to a beauty supply store and get the items that she needs, they deemed that was not an essential business. But at the same time, they have, what's the beauty supply store? Sally's. Sally's Beauty Supply Store is still open. They have curbside service, which to me, Sally Beauty, as well as the local beauty supply stores have the same essentials for the community. But because those Sally Beauty Supplies are in different zip code and serve to a different target market, they've allowed them to have curbside service when the beauty supply store here has a drive-through, but they still, they've shut that business down. So those are just a few things that I have that I wanted to share when it comes to the community thoughts and their experiences with COVID-19.
Thank you so much, Mia, for sharing your stories and the community stories.
Thank you.
I just want to remind everybody that if you have any questions, put them in the Q&A, and all three of our panelists will have an opportunity to answer at the end. So next up is Karen with St. Louis Integrated Health Network.
Hi, good morning. My name is Karen Bradshaw. I am the director of the Community Care Transitions Initiative at the IHN, and not knowing who everyone is on this webinar today, I know some of you have probably worked with some of my very talented colleagues who concentrate on maternal child health and wellness, but I truly welcome the opportunity to come to you all and talk this morning. As I give a little brief introduction of myself, I am putting a quote on the screen, and I think having had Mia just highlight real experiences of folks living it right now during this pandemic, I put this quote on here that I have used with a couple conversations, groups, meetings that I have had over the last couple weeks, because it really does ground for me the reality of the disparities that many of us knew existed before, but for a lot of the population are becoming so apparently evident right now in this pandemic and in this crisis. I do represent an organization called the St. Louis Integrated Health Network. We are a nonprofit intermediary organization focused on working with those individuals and organizations who have barriers to accessing quality, affordable, accessible healthcare. Our membership of the IHN, who our board of directors is, are all 4 of the federally qualified health centers in the city of St. Louis, the city and county health departments. All 3 health systems, Mercy, BJC, and SSM, sit on our board of directors, as well as the 2 medical schools, the Regional Health Commission and the Missouri Primary Care Association. Our mission, if you can go to the next slide, please, Sarah. The mission of the IHN, just to you know where we're coming from, is again quality, affordable, accessible healthcare for all, but really with a specific focus on those folks who are considered medically underserved. Often that is defined as those folks without insurance or on Medicaid. We will define it as anyone who feels they cannot access services or getting the quality services that they need. I do not limit it to a payer status. When I talk a little bit about the program that I run, I never limit it to payer status. There are a lot of factors that impact people's ability to transition levels of care and receive the care that everyone is deserved. Today I was asked to come and talk about not only the IHN's response to COVID, but our role inside of a few other regional efforts. And I will try to get to that as soon as possible. But like so many organizations and people and families, I happen to be a single mom myself of 3 kids, and everybody has had to stop and adjust. And the first thing you have to do is like stop and adjust for your family. I did just like give the very clear thing to my children that no one is allowed to come in here for the next hour. You know, all of those instructions, we've all had to regroup, homeschooling, all that stuff. The IHN had to do that as well, like a lot of organizations. We had to quickly stop and pivot and think of new ways to do what we were already doing. We had to do some internal work really quickly to comply with laws, make sure we had supports for our staff. I can tell you I've had the experience already of putting staff on emergency sick leave. We've had staff people diagnosed with COVID. I just moved somebody from emergency sick leave to emergency family medical leave. So we've had those very direct experiences as an organization and having to pivot. And then two of our main programs, which I have listed on the slide, the Community Referral Coordinator Program and the Relink Community Linkages Program, are a lot of what the IHN does is coordinating, a lot like Generate Health, coordinating other organizations who are involved in similar work to make a larger impact. However, we do have two direct service programs. We are directly working with people, and those are the two programs listed on here. Relink Community Linkages Program works with justice-involved youth, 18 to 26. It is folks that have had experiences with the justice system, specifically leaving the workhouse, and being partnered with community health workers to look at reentry from a health and wellness perspective. This program continues in this time. We've had to adjust to have community health workers doing a lot more things remotely and keeping in contact with the folks they're working with, who are also experiencing different levels of barriers and needs based on COVID. And then the program that I'm the director of, or one of the programs I'm the director of, is the Community Referral Coordinator. This is our largest and longest running program with the IHN. It's been around for about 12 years. There are 16 other folks involved in this program full time, 12 of whom are directly placed, they're called Community Referral Coordinators, directly placed in 9 area hospitals in our region, including the 2 children's hospitals. CRCs, as they're known, work with folks who are either in emergency rooms or inpatient units and have to transition from that very acute healthcare setting to an outpatient setting. We focus on those folks with chronic disease. In the pediatric world, it's predominantly asthma, eczema, and other conditions, but those 2 are the top 2. I have 2 CRCs who focus solely on peds in hospitals. I have 10 other CRCs who focus on adult populations. And then we have 2 community referral coordinators who spend their time in community trying to work with folks, especially those with chronic disease, before an emergency happens, connect to primary care and manage those diseases. So those are tough jobs, and it's a big ask. In non-COVID times, as when COVID hit, we had to adjust. None of those folks are currently in hospitals. They are doing remotely. We still have access to the hospital EMRs. We still are receiving referrals, but we've had to pivot to not only serve the folks that we normally do, and my team sees about 20,000 people a year. We are adding paths and navigation for folks who are diagnosed or presumptively diagnosed with COVID-19. As Mia talked about, there is a substantial lack of testing in this region. There are a lot more testing sites. However, the actual number of testing kits is significantly less than what is needed. And so the majority of folks are not being tested still. There's still the criteria of having direct contact with somebody who is positive tested, which makes for a circle that allows for a lot of folks not to qualify. Even in emergency rooms, when people are there, if their symptoms are not severe enough to warrant admission, many folks are not tested. They are told they are presumed positive, which is a very confusing thing for folks. So CRCs spend a lot of time navigating, planning, and so we've really had to pivot to continue to be able to serve the folks that we do. Most, again, in the adult world, 80% of the folks we see have chronic disease. The number of chronic diseases is averaged 3. How do you still care for yourself? How do you still get your insulin if you have diabetes? If you have heart disease and you're at higher risk for COVID, how do you get what you need without leaving your house? CRCs focus a lot on that. So we've had to pivot to make sure, even remotely, we are still doing it as much as possible. And I'm going to tell you in just a few minutes an exciting program the IHN is adding right now. But first, we had to do these things before we even do what we do best, which is some regional activity. If you can go to the next slide. Sorry, I could have gone here. This was just an overview of the Community Referral Coordinator Program. If you are interested, this lists the hospitals where we are. Those hospitals that have asterisks next to them have 2 CRCs, one specifically for the ED and one specifically for inpatients. All other hospitals do both. The the thing that I was asked to come and talk about today is what's called the COVID-19 Regional Response Team. This response team was formed shortly after the crisis was really known and identified. And it's a bringing together, it's headed up by Jason Purnell, who's a professor at Washington University. But bringing together organizations, people doing this work to try to make a coordinated response. As many people remember, the counties that you see on this diagram made some decisions as a region before the state of Missouri made decisions. The state of Illinois certainly came out earlier than the state of Missouri in stay-at-home orders and having to take action. But this region came together and made decisions on schools, stay-at-home orders, and because of that, these counties chose to make this regional response team to really try to coordinate efforts in response to COVID. There are a couple different arms of the regional response teams. There's some basic needs. There's medical and physical and behavioral health, I think, is one of them. That's why Sally and I are here. Both of our organizations, one are closely aligned in normal times. I don't know the right terminology anymore. But we also come together in this work to really make sure all of the organizations who make up our organizations are involved in this response. The regional response team has named 3 areas that they call strike teams. These strike teams are looking to really either put up or create or respond in very direct ways for the 3 bullets outlined below. The 2 that are blue are the ones where the IHN is having more direct involvement. I can tell you that the school and food group is very, very active. I just can't tell you a whole lot about it. It is not where I have time or expertise. The IHN is involved in the first bullet, the homebound older adults and person with disability strike team, and then also in the conversations regarding services and supports for those who are unhoused. If you can go to the next one. Sarah, can you move it to the next slide? All right, I'm hoping.
I'm gonna keep trying though.
Okay. I'm pretty sure the next slide I was going to talk about is the work for folks who are unhoused. Yeah, there we go. They're calling it sort of medical supports for the unhoused. I will tell you it is inclusive of physical, behavioral health, and substance abuse. And again, Sally Haywood and I are close colleagues. We work closely together. And I've been involved in lots of conversations, both facilitated by the IHN and the BHN, on these issues. Anyone who's done work with folks who are unhoused knows that it is complicated. Not only are the individual situations that have led to folks experiencing housing insecurity complicated, nuanced, and individual, there are lots of players in this space and in this area, and you can't go without government, and sometimes there are frustrations with inefficiencies, and there are not enough shelters. There are not enough supports in, again, normal times. It is exacerbated now. So we have broken out sort of the conversations and the work in 3 areas. Many folks are aware that there are encampments. There are always encampments, but right now people are more aware because there are more encampments, and some of them are in more visible spaces. There are 2 right off of Market Street that I think have gotten quite a bit of media attention or pictures so that people are more aware. Again, there are always encampments of folks who are unhoused. Just right now there are more. We have right now we are looking and working with about 15 encampments of folks who are unhoused, and some of these are groupings of tents, other temporary structures, and they are really looking to provide medical screenings for COVID. As anyone who knows about the COVID illness, it is highly easily spread, and folks who are experiencing housing insecurity often have multiple chronic conditions, making them more susceptible to the actual disease of COVID-19 as opposed to just contracting coronavirus. So they are looking to do medical outreach and screenings to the encampments multiple times a week, potentially daily if we had enough staffing and volunteers. But in any type of screening, anyone ever on this call has worked with me, screening in and of itself is never the right step unless you have an answer when that screening is yes. Screening people for diabetes and hypertension is not helpful if you do not have a plan to address it when they screen positive. In the same way, we have to make sure and advocate for very clear paths for folks when they screen positive for symptoms of COVID-19. Meaning if they are positive, where can we provide safe and secure shelter for people who need to self-isolate and or quarantine? The work then also is you are going to find folks who have medical needs and chronic disease who will need to have those things addressed as well. And then also, it is very well known that folks who are unhoused often struggle with behavioral health and substance abuse issues. So making sure these outreach teams are comprehensive in what they can provide or how we get people the supports and help they need. This is complicated. I can't happily report that we have this all laid out and it's happening right now. Some of this stuff is happening because it was happening before sporadically. We have not yet stood up a full and comprehensive like regional push, but there are proposals and many of us are working a lot of hours to try to get some of this put together and make sure that there are clear paths for safe and secure shelter. So this work is continuing. I can happily answer questions that I know of, but there are lots of us in this area. The next update I can give you on the regional response, and this is one I can happily say something is being stood up and happening right now. The IHN in particular has received the funding through the regional response to literally launch and stand up right now. The job descriptions are on our website. I have it for you at the end of my presentation for what's called Homebound CHW program. CHW stands for Community Health Worker. These are an amazing workforce that has been around for decades and in other parts of the world are well established part of the medical and healthcare systems. Community health workers are folks that know their community and can make connections that otherwise wouldn't be there. This is a 3-month program right now. We are hiring 10 community health workers, additional community health workers, 2 community health worker supervisors, and these folks will be coordinated with 211. If you're from the St. Louis region, 211 has been the central number given out for people for resources. Their number of calls has tripled or quadrupled on some days compared to past years. And the needs are immense. We know this when we've seen the food bank giving out food or Urban League or things like that. So what this program will focus on is those folks who we know are at extreme risk of developing COVID-19 because of their pre-existing conditions. This is focused on the city and the county, but predominantly North County. This team will work with referrals made through 211 when people are identified as having at least someone in their household 50 years or older. And there's folks that have those multiple chronic diseases or any of the chronic diseases that we know make them more susceptible for COVID-19 and have social needs like food emergency, medicine needs, any other social determinants of health that are identified. They can be assigned a health worker. The health worker will be in contact with that family and certainly try to coordinate those needs to limit the amount that the folks have to go out to get them. There is a small amount of funding assigned with each family to eliminate some emergency needs, to really help coordinate some of this response. Calling and getting numbers of other places you can go, for a lot of folks, that is daunting. And community health workers have experience and knowledge of how to navigate or help folks navigate. So literally, we just did this. We just put the job descriptions out yesterday. And we are looking to interview as soon as the end of this week to try to get this stood up and in place as quickly as possible. If you can go to the next slide. The other huge effort that the Integrated Health Network has been a part of was to also get out a campaign called Prepare STL. I'm certainly hoping that this is not new to some of you. Prepare STL, the website's at the top. It is a whole collaborative campaign with funding from the Missouri Foundation for Health, the 2 health departments, as well as the Regional Health Commission. Along the bottom, you can see the other, what they call community partners. IHN is one of them, Mental Health Board, Alive and Well, and the Community Health Worker Coalition, have really come together to focus a communication effort specifically for the folks who are being most impacted by the devastating effects of COVID-19. We have not only had a website, there's also Facebook, Instagram, all of those communication ways. Last week on Thursday, 95.5, the radio station took the whole day and spent it on COVID-19, interviewing folks with Prepare STL. There have also been canvassing campaigns. I promise all folks who do our canvassers or provide proper PPE training and all of that, but in specific zip codes, specific neighborhoods, specific types of locations that have remained open, like laundromats, dollar stores, and other places where people frequently go. These canvassers have shared information, put out placards, posters, trying to get the word out with accurate information, how to access testing sites that are now available at community health centers. It is slower, it is delayed, it is unfortunately the history of St. Louis that it's happened that way, but we do now have 8 that I can think, I'm off the top of my head, 8 testing sites at community health centers by the end of this week. Affinia will have 5. Care STL has 2, with 1 coming back online next Monday. And People's Health Center up on West Florissant in North County is testing every Friday. I'm certainly available if people had questions on that, but getting that information out, how to call, how to access, Prepare STL is really trying to push that out there, and they're trying to think as creatively as possible of continuing to get accurate information out there, dispelling myths. If you can go to the next slide, there's a lot of resources on this site if you haven't gone. There are videos, there are instructional videos, how to wear a mask, how to do this properly, how you can keep them going if you have disposable ones. Anything like that. This picture's a little old, I apologize. It says as of 4/8. I can tell you if you went on there now, it would be more updated. That this is out there with, again, trying to get people accurate information. We will make sure that Prepare STL is already linked to the regional response website, to 211, very much trying to link all this stuff together through the regional response, but the IHN has been very involved in making sure that this is health literate, that it is accessible, and that, again, by including Community Health Worker Coalition, that it has folks who are going to say this is what's important, and being driven by folks in the community on what's needed. There's a lot of videos on there too, from Dr. Lori Punch, who does a lot of work in the region on trauma, but has really switched right now for focus, seeing the parallels of those affected by trauma and those affected by COVID, and giving her perspectives and trainings as a medical surgeon to help people understand and protect themselves. Next. So one of the questions I get asked when presenting today is how can people get involved? These are the 2 things that the asks that I have for all of you. If you'd like to learn more about the IHN, of course, you can go to our website or you can contact me directly. I can certainly put my contact info in the chat box as soon as I finish. But the 2 ways that I really ask folks, regardless of what organization you're from, what share, even if it's just sharing on your Facebook or Instagram or whatever social media account, go to Prepare STL, look at it, share it with your networks. There's really good info on there. I guarantee you people can learn stuff no matter how much they think they're an expert. To share that, to get it out there and trying to get good information to the folks that need it. The second is the website here at the IHN. It's right on our employment page. All of those health worker positions that I talked about, they are 3 right now guaranteed 3-month positions. The hourly wage is on there. We give a stipend to help pay for health insurance on the marketplace. And there's a lot of us, myself included, who will help folks navigate that. There's all the descriptions. I can also answer questions, but we try to always be as transparent as possible. but those jobs are there. And if you know folks who would be interested or know their communities well and would like to get involved, please send them our way. We are doing this as quickly as possible to get this up and running because we know folks need this service and support now. I am going to turn it over to my colleague and friend, Sally Haywood from the Behavioral Health Network, to talk a little bit more about what they're doing, but I will be on and remain available when you do questions at the end.
Okay, Carrie, did you want to say any more?
Oh, I don't know if that just unmuted me. Hold on, sorry. No, Sally, you can take it away. I
Right.
just wanted to thank Karen real quick for
Oh,
all of
good.
that information and the work that you guys are doing. But absolutely, Sally, we're ready to hear from you.
Great. So the behavioral, can you go to the next slide? The Behavioral Health Network I consider us like a sister organization to the Integrated Health Network, focusing on behavioral health. Long back in the beginning of the discernment was that as the region needs advocates for the safety net system to help folks engage in healthcare, the uniquenesses of the behavioral health system merited folks lasering in particular attention in that arena. So we focus on the safety net, uninsured, underinsured, all levels of severity and points in the age life course, youth, and we focus on 7 counties in the eastern region. Next. So I thought I'd share today, similar to what Karen was saying, is how behavioral health providers have been pivoting to working virtually, and then some of the new COVID-19 response efforts. Next. Is a little back story is Behavioral Health Network, we do not provide any direct services. We have been asked on behalf of our constituents, many of whom are also on IHN's board, but also encompass other community mental health centers, substance use providers, community advocates, and the behavioral health leaders of the major hospital systems. At various points in time had said that they wanted to launch an initiative and said, because we want it to be regional, BHN, would you do the planning and coordination, but the contracting of the direct service providers happen through our partner organizations. So we have 4 major outreach initiatives, all under the umbrella hospital community linkages, that help patients transition from an acute behavioral health episode, and behavioral health, we mean mental health or substance use, and help them engage in ongoing community care. And those 4 initiatives have about 30 staff collaborating with about 11 behavioral health providing organizations and service about 3,000 patients. And it's a longer term, usually more intense outreach, case management partnership to support somebody to make that transition. Some of these folks are some of the most vulnerable, ill in the hospital systems. In the emergency room enhancement, about 60% of the referred patients, all our referrals come from hospitals. About 60% of the high utilizers are unhoused. In Epic, folks who are referred because they presented to the hospital with an opioid experience, an overdose, a good 45% of them are unhoused. So very, very vulnerable folks. Next slide. So here is a list of the contracted partners who have 1 or more staff who serve on these regional teams. Just so you have a sense of who our key players are. Next. And the service delivery pivots. So first of all, the hospital said we want to minimize the amount of people coming into the hospital. So outreach staff, we want you to do telephonic only, or when possible. And it's been a challenge to get video going. It has to be HIPAA compliant technology, often people working off of laptops or their phones. We're trying to engage with patients. So how, what technology do they have access to? A lot for these programs have mostly been going on. The oldest is 9 years old and the youngest is the youth emergency room enhancement is about 3 years old, where outreach staff are called and they go to the hospital right away regarding a referred highly vulnerable patient. And so they are not coming. That first encounter is a facilitated experience with a hospital staffer trying to get the outreach person on the phone and then get the patient on the phone. And it's more finagling and challenging. A lot of the folks it's new and they're not so comfortable with doing the video services, or somebody who's in the ER or in the inpatient unit with full-on psychosis, it has more trepidation about using technology. The other thing about so I just want to say the impact of going telephonic and video on services is real. Referrals have decreased, but those who are being referred are usually far more ill and far more vulnerable. The EPIC program that has recovery coaches who are hired for their lived experience in substance use recovery, when they present to somebody who's just been life resuscitated from opioid overdose and they are bedside in the ER and they said, hey, recovery is possible. I did it, you can. The engagement rates are not just outreach, but engagement in substance use services are at 45%, where referral from ER to substance use services nationally for opioids is about 7%. So lives can change, but how the engagement rates for EPIC, for example, when it's telephonic and video, are diminished. Meanwhile, the community mental health centers and substance use providers are still providing services. They've all had to pivot. Once you are, you receive outreach, which are the programs BHN helps manage, the admission processes. Usually you present at the clinic and have an admission process with your diagnostics and your history and your health status. They've had to pivot to making that happen virtually, which, by the way, could be a fabulous thing long-term. So many of the things we're needing to figure out to be able to function during COVID could have spin-off benefits for the long term. Many of the provider organizations are still doing walk-in services, mostly for their existing clients for essential services, such as in long-acting injectables for antipsychotic medications, which is a once-a-month shot. They're still doing social distancing, so negotiating, doing medication drop-offs at some of the most vulnerable folks' houses. Assertive community treatment teams are within community mental health centers who it's the most intensive level of service, with a team of medical and community support specialists who help folks learn living skills and manage their medications and their chronic health conditions. Those teams are fully masking up, gowning up, and still going out and meeting with clients. And many of the substance use and community mental health centers still managing residential services, but they are minimizing new admissions, trying to maintain absorbing the expenses of increased cleaning and processes to keep their existing services going. Next slide. So some of the challenge areas, I said, while hospital census is, a lot of us are there's a wide hesitancy to present at hospital, but those who present, the needs, particularly with a behavioral health need, the needs are pretty severe to have compelled somebody to go present at hospital under these circumstances. So the discharge planning with technology and the expedited admissions is one of our biggest challenges. And doing admissions to diminished capacity of the provider agencies to deliver services is also a constraint. They are, we are trying to negotiate how to put a much more personal protective equipment on outreach staff to meet some of the most vulnerable folks at the hospital or in community, because some folks whose lives and conditions are so complicated, this telephonic support is, no matter how creative we are, it's not enough. And I mean, to give a sense of it, some people are discharged to housing instability, and we had an outreach staffer, for example, who the patient had barely managed psychosis with substance use disorder, and he was living under a bridge. And the outreach worker would, found him, met him, and he says, "No, I'm good, I don't need anything." And she just sat and talked to him and made contact, and he says, no. She went back every day, and she'd bring water or apples or a sandwich or a blanket. And finally he said, okay, I'll go do an admission. This was a story that happened just prior to COVID. So he went, spin forward some weeks, he got on an antipsychotic medication, got admitted to substance use recovery treatment services, and was expedited to be in sober living housing after residential treatment, and is in a virtual job readiness training program right now. So that's the level of need and the level of outreach that we're talking about with many of the clients. I'm pleased that Karen went first, because she, some of the efforts that we're working on together, the amount of needs in the shelter and in the encampments for folks who have moderate levels of anxiety that are extremely exacerbated by current circumstances, or some substance use concerns that are accelerated into substance abuse, it's exponential right now. So trying to see how we can amp up the amount, particularly the amount of substance use recovery services in shelters and encampments. Next slide, please. I wanted to talk also, your moderator sent us questions about also what we're doing in the intimately with the communities. Behavioral Health Network, we're 6 years into building a Bridges to Care and Recovery infrastructure that works with now we're up to 86 primarily African American churches in North City and North County to reduce behavioral health stigma and connect people to care. So a lot of folks in these communities, for a myriad of good and legitimate reasons, were organized service skittish. And so they might take their behavioral health need to their pastor, who usually felt ill-equipped to attend to the needs being presented to them in the realm of serious mental illness and substance use, addiction. So it's an intensive training for pastors and lead staff and lay leadership, and then training an army of wellness champions. Many people have gone through the wellness champion training, but at any point in time, we have about 125 currently active champions who are volunteers who take their referrals not just from their congregation, but anywhere. You know, it could be a congregant's nephew or, you know, neighbor. And then we have 2 staff community connectors who support receiving referrals. And they are, next slide, if you would, continually working to raise COVID awareness, provide safety tips, provide information and refer resources about behavioral health services, and continuing to do training to churches on a variety of topics. So I know those staff are in continuous web-based meetings, and Bridges infrastructure is working diligently, just differently through this crisis. Next slide. So another piece, now I'm transitioning to what's new. So as Behavioral Health Network was invited to be on the COVID regional response team, along with the Integrated Health Network and other providers. And the St. Louis Community Foundation received philanthropic dollars and was asked, would you distribute these on behalf of the community to respond to COVID? So they had 2 rounds of allocations, and BHN applied on behalf of our constituents. The first one was funds that were distributed to those 14 agencies that participate in the hospital community linkages program to support what we call flex funds. So an outreach worker might be talking with somebody, trying to engage them in behavioral health services, and the client might say, you know, look, lady, I don't want what you're selling. I need a place to stay. Or I just came to hospital straight from a home situation I can't go back to. I just need a change of clothes. And they can say, that's great. Let's go take care of that. Let's make it happen. That's what, or they discharge me with a script and I can't get the meds. So flex funds can attend to immediate barriers to engagement in services. And we've had access to flex funds historically, but through Department of Mental Health. But these flex funds could also respond to COVID-related client needs, such as phones or food, being able to shelter in place, access to a myriad of things. The other 25,000 cycle that we were allocated, we were distributed to small behavioral health safety net agencies that had limited resources. The amount of cleaning when you're still having patients come in, or telehealth equipment or software, or other small agencies that have not historically had flex funds. Next slide. And so this is repeating, letting you know about the COVID-19 regional response team. Next slide. And how BHN, our role with that team is, our leadership of BHN have been participating in on the team to bring information to the team and bring it back from the response team to the behavioral health providers. We've been hosting weekly meetings of executive level leadership from the hospitals and the agencies, and another weekly meeting of outreach managers. And a huge focus of those behavioral health leadership meeting has been around responding to unhoused folks and the discharge process from hospital to what. And we have a grant where we were looking at system changes around complex care patients. Well, this is dovetailed just fine, because right now there's an openness to working collaboratively on some of the most complex patients that we hope again will have benefits over time. And we got the Community Foundation grants. And so similar to the newly funded initiative that Karen talked about, that the IHN is leading, we highly expect that the FEMA, the Federal Emergency Management Agency, will make an allocation to the Department of Mental Health, and Department of Mental Health has asked BHN they will funnel those funds through 3 of the largest community mental health centers, and said, BHN, would you work with those partners and come up with a regional plan for a FEMA initiative called Crisis Counseling Program. And Missouri's been funded for this, it's disaster response. It's not response to clinical behavioral health needs. It's crisis counseling, public education, whole infrastructure and network. So we're on daily calls trying to put that plan together and see if FEMA will release funds. I'm going to go through the next couple slides very quickly because I'm mindful of time. Is part of our role with the COVID response team, we did a survey of behavioral health providers from primary care settings and hospitals, and then some of the findings and the needs. Can we go to the next? Some of the greatest needs have been for telehealth. A lot of folks were not set up or equipped to do that, and the clients were not equipped to participate in receipt of services. Maybe they have a government phone and they are offered outpatient counseling, but they don't have enough minutes to be on the phone that long. Or a lot of the interventions that are being delivered telephonically or via video were not, the payer sources, the insurance companies were not reimbursing. Some recent changes in what Medicaid will pay for have made that more feasible. And the needs, the amount of requests for services. Meanwhile, as Karen said, the agencies providing the services have staff on medical leave, and it's the influx of requests with the compressed ability to respond has made some enormous demands. And reduced revenue for service providers, such as, I know Karen often talks about the challenges of the health centers that are much more revenue dependent. So if people aren't coming in for services, they don't have the revenue to maintain the staff, and there have been some furloughs or some agencies that said you can keep your job, but you have to go to a 32-hour work week and commensurate reduced pay. And so it's challenging. Next slide. Okay, and the agencies, we said, what are the clients you serve? What are the greatest needs that the agencies and the clients they serve are experiencing? Housing and food insecurity, top of the list. Next. So again, reiterating the barriers. Shelter options. I think you're well aware that in the news, a lot of innovative, increased responses to trying to provide shelter in place options for people who are COVID positive, COVID presumptive, waiting for COVID testing results, or just the increased sensitivity to the existing homeless situation. There's also a big need right now is there have been discussions that people would like to donate personal protective equipment, but who could receive that and manage the allocation of the donations? And also there have been some calls for volunteers to visit the encampments, for example. But if I were a nurse and willing to volunteer, like, who should I contact? So this lack of the challenge of matching resources with need and getting those deployed is huge. Okay, and I think last slide is one of the requests that Carrie and her colleagues put out to us is, what's something you can do? And we got another grant through SAMHSA, Substance Abuse Mental Health Services Administration, to improve services to transition age youth, people 16 to 25. And part of that is a public media campaign. It was something we were planning before. And now we're asking young adults to, if they would do a very quick selfie video and post it on their public media and to the hashtag Help Is Here, and describe how are they living and what does their life look like living in quarantine, and if they have a behavioral health concern, how's that going, and how are they managing it under the current situation. And there's a $25 gift card that will give young people who do this for as long as we have those gift cards. And I know Carrie will, I'll put we posted it on our website. I'll put the brochure in the chat box. Carrie, I think that's it.
Perfect. Thank you so much, Sally and Karen and Mia. At this time, I wanted to throw it back over to Mia and see if there was any information that came from Karen and Sally that caused you to have more questions just questions of anything else that's happening and how you address that to your community.
Oh, well, thank you, Carrie. So one issue that I wanted to point out that I don't think that was addressed is in the Black community, there are a lot of kids that are underdiagnosed, misdiagnosed with having mental issues. And for a lot of parents, they were able to work together with that school district and work as a team with that school district, as well as summer programs and being able to have that accessibility, as well as having a quote unquote break from, dealing with the stresses of taking care of a child that have mental and physical disabilities. So with that being said, I've dealt with community members that were looking for respite care for their children. And I recall had to been like half of my day calling agencies looking for respite care for this particular mom. And that list is, it's a long waiting list for those parents, which in turn is causing, there's a lot of child abuse going on right now. There's a lot of kids that are in vulnerable homes right now. I mean, they're being physically, mentally abused. And it is, I look at the parents, I look at it from both ends, that you're talking about parents that may have a mental illness themselves, as well as a parent that just snaps. And it just becomes so much when you're dealing with, if not one, multiple children with disabilities, and having, at this time with COVID-19, which before you could call Crisis Nursery, you could call Bethany Christian Services, and so on and so forth, Family Forward. But at this time, these parents are like left in the dark when it comes to having that support for their children.
Yes. All of that, yes. I don't think either one of us addressed it. When I laid out the regional response team, I did say there's 3 strike forces and there's only 2 that I could speak to. I do know I have colleagues, not from the IHN, but other colleagues that I've known in my 10 years of working with the IHN on the 3rd strike force that has to do with school and kids and families. I just can't speak to their work and their efforts. I did just write down really big on my paper respite care, because that's one thing I don't know, but this could be, Carrie, something that you all could do a webinar on, or I could help connect you with folks who are on that team specifically looking at families with school-age kids and the needs that are coming up. That is just not anything that I feel like I could address specifically. I hear conversations and I'm on a once-a-week update kind of call, but I sadly can't tell you, except for the fact I know my team when they're connecting with families who may have gone to Children's or Cardinal Glennon or just know my teen, they are talking about a whole breadth of issues, and especially for kids that were getting services from special school district, which is where you started.
Right.
I know one of my staff folks called me yesterday looking for what can I do. The place I normally would like reach out to isn't open. So you're right on. I'm sorry, I can't provide more info. I just don't want to give something that I don't have the expertise in, but you are absolutely right on that many folks are experiencing this, not only in aspects of child abuse. I know that there's concerns for domestic violence, just all of those factors when home isn't that safe place. There were initially a lot of efforts when we knew schools were not going to be open every day for food, but there are all of the other aspects that are provided through school. And I know that that team, or that they call it a strike force, is focused on that. I just can't speak to all those efforts.
Okay, thank you, Karen.
Sure.
They, similarly, I'm going to post the Bridges to Care and Recovery referral number, that if you want a partner in trying to discern, as I was saying, a lot of the providers are still aiming to offer something. It's just not what they used to be able to give.
Right.
So I will post that phone number, and then folks can say, hey, I'm searching, but will you partner with me to search for an option? Because it's daunting to try and figure out, okay, who can help right now under current circumstances.
Thank you. I don't know. I don't think this was addressed. So dealing with the community and centered around trauma, has there been any platform for the community members to access therapeutic services via using, Zoom or things of that nature? Is there a platform for, because I feel like at this time, with everyone being at home and having that accessibility and the time, so to say, to kind of focus on their mental health just because it's being compromised with the COVID-19, is there a platform for the community to directly reach out and receive services for their mental health?
And again, I'll post something. Department of Mental Health has launched a website where anybody could get telephonic or video counseling who calls. And I've really been pushing that phone number for staff and health workers and first responders, but it's open to anybody in the public. Also, again, through the Bridges to Care and Recovery, we have a grant with about 4 counseling providers who historically were offering telephone video counseling because the stigma is so intense in some communities. They said, I don't want to be seen going to that place, or I don't, I don't have childcare and transportation, so I got to have an option different. So as I love how Karen says, some of the problems that are exacerbated right now always existed. So that some creative inroads we made before, we're getting to build on them, or we're building things now that I hope we get to keep. So here comes the Bridges number, and then I will share the DMH one in a second.
I would also add to that behavioral. So if you call 211 right now, hopefully they've changed the wording. I haven't checked in the last week, but if you call 211, it does highlight our, if you're calling for social needs, or if you would like someone to talk to, there is a direct connection from 211 to behavioral health response. Behavioral health response also has a 1-800 number, which either Sally or I can share, but they will also take anyone's call 24 hours a day. It is a crisis line, but they are all licensed folks who can walk people through the feelings or the issues right then, but also try to connect to services additionally. And then I'd also will throw out there, especially with a trauma-informed lens and a racial equity lens, Alive and Well Communities is also doing a lot right now they've always done a lot, but they're doing more in direct relationship to COVID. They happen to have, I think they call it Daily Dose, but it's also a social media thing where they bring different people on every day at 10 a.m. Happens to be the same time, but and do everything from yoga to talking about stigma in the community to doing things like that. So I highly recommend Alive and Well Communities. Again, because they are working with agencies and providers on being trauma informed and better aware in the services that they provide, but they are also doing a lot of supports for folks that want to connect or communities as a whole.
Thank you.
So can I also jump in? There was a request or a question of Karen, can you provide information for the school family strike force? Or is that information on the STL? Good.
The website for the regional response, it's so weird. It's, let me pull it up. It's like C19 RRT. Give me 1 second. And I will put in Prepare STL's website. For who they should contact for the school strike force, I would say Carrie or someone, we could contact Jason Purnell directly and figure out who the exact person or people should be. I do not want to, again, that's the one I have the least contact with, and I don't, but I can get it for you all.
Sure. And we can contact him and then put it in our resource
Perfect.
guide that we send out after this. And then, so there's 2 other questions that were sent to us. Unless Mia, you have something else that you wanted to ask or bring up at this time. I'm just being conscious of everyone's time.
Oh, okay. I mean, as far as Sarah so kindly put it, the crisis, as they call it homeschooling, but it's the crisis schooling that is going on right now. I know that's been an added stress for everyone, including myself, with everything just being uncertain and the question mark as to when the end and when the ending of this COVID situation is going to, lock that date in. No one knows. So yeah, that's been a huge concern with everyone with schooling. The significant increase in the anxiety with the Black elder community, of course, dealing with them being the most vulnerable right now. So we have a community member that does home health care for a few different elders, and that has been a major concern of hers, is dealing with their anxiety and stress right now with just being sick and the fear of death. I know was there a question for me, Carrie, with the Walmart situation?
The what question? I'm sorry.
Was there a question involving the Walmart?
So not that I have been sent. And I think the information that I'm getting is that it was answered.
Okay, I'll touch on that real quick because I know that was one of the first questions. So coming from the manager at that Walmart on West Florissant at 270 at West Florissant, the manager, Leslie, when I spoke to her and asked her what was the reason why children were not allowed in the store with an adult, her response was to keep the foot traffic down. And I said, who put this policy in place? And her response was the home office. I asked her, why not all of the Walmarts implement this COVID response policy, and why just this particular Walmart? Her response was, it's our jurisdiction, and it is the decision of the marketing managers to put that policy in place to not have children at the Walmart at that time.
Thank you, Mia.
Thank you.
So 2 other quick questions because we're running on the end of our time for our webinar. One of the questions is how long between testing and results at this time? And the second question is for Sally, when you're talking about the churches, what's the success rate of this program engaging churches to participate when so many people don't feel comfortable going to church or don't have a connection to the church?
Sally, I'll take the testing if you take the church. Testing is a loaded question and a loaded answer. It really depends who, where, when, and why. So there are multiple ways of testing and multiple providers. So there was a very, very long delay, as much as 7 to 11 days for some folks a couple weeks ago. Depending on where the testing is done and where the lab is that is connected to the testing. I know this is not a very straightforward answer, can lead to different things. There is some testing available in some hospitals where you can get results within hours to 1 day. That is typically within hospitals, and that is typically for people who are admitted. I do know of one ER in the region who has expanded some of that testing to people in the ER. When you're using the community testing, either the drive-through or one site at Affinia also has walk-through specifically designed for unhoused folks. That testing is often connected to private labs. So like a Quest or a LabCorp, they can have somewhere they stay between 2 and 5 days. I have heard it go longer, but I believe the throughput is getting faster for the majority. It's just hard to get accurate information on the testing part because there is still a lack of testing kits, and then the back end is where the lab is. And so it's sort of not a blanket answer. So I apologize for not being very short. We are hoping, and I happen to hear the county executive this morning talking about that the county council for the St. Louis County passed funding last night, and they are hoping to spend $7 million on testing, or so most of that, to increase the capacity. I think our providers, including community health centers, have the capacity to do significantly more testing in a day throughout the region to do better testing. However, we just don't have the actual tests. Once we get all those supplies, I think there will be an increase and a loosening of the criteria. But right now I'm hearing community testing is anywhere from 48 hours to 5 days.
Thank you, Karen.
Will you repeat, Carrie, the question about churches?
Oh, yeah. Let me pull it back up. Sorry. So the question is, what is the success rate to this program engaging churches to participate when so many people don't feel comfortable going to church or don't have a connection to a church?
So usually the success rate has been amazing, engaging church leaders, whether it's the pastors, the associate pastors, the executive council, or saying, yes, we want to be smarter, do better, know more how to support our congregants and their families with mental health and substance use needs. And I have to say, over 5 years, it's been a long road. There's organizations of pastors where you get a champion who says, you know, I didn't know what to say in years past. I went through this training, a congregant came to me, and I of course, could pray with them as I always would and provide spiritual guidance, which is my expertise. But then I was able to engage the expertise of community mental health and substance use providers. Now, I'm hearing in the question that there are many individuals who are not comfortable with church. We're not reaching them, or we're reaching them secondhand. So it's a entry to the churches, church leaders, and those leaders recruiting wellness champions within their congregation who then penetrate the congregation and their community. But if somebody continues to have a distrust in church or church affiliated people, they could still call the referral line and get to services. There's no faith requirement. But it really is a means to support the people in those leadership paid and volunteer roles to reach the people in their community and in their contact network.
Thank you. So we went a little over, and I just want to say thank you for your patience. And to Mia and Karen and Sally for the wealth of information that you were able to share with us today.
Thank you.
I also want to say thank you to the Generate Health team, who is working behind the scenes to get us all the questions and advance the slides and do all the things that make this event a success. And again, thank you to everyone for participating and for all that you do to care for moms and babies in our communities. Following this call, you can expect to receive a link to this webinar, the compiled information and resources that were shared, and a quick survey to help with the planning of next week's call. Please share the recording and resources widely. Generate Health will continue to host these weekly webinars for as long as they are helpful. You can join us again next week on Wednesday, April 29th at 10 a.m. So thank you, everyone, and remember, stay safe.
Thank you. Thank you, Generate
Thank you.
Health.
Thank you, guys.